Hello everyone. Good evening.
Sir, good evening.
Hi, good evening. Good evening,
Sir, you're
everybody.
traveling, sir?
Good evening, sir.
No.
Jitu sir, good evening.
Hi, good evening. What's up?
Hi, Dr. Jitendra. Hi.
Hello,
Good
sir.
evening, sir.
Good
Good
evening,
evening.
Joseph.
Good evening.
Okay.
So you're returning back from the meeting, right?
Harsh,
Yeah.
no. I didn't go for any meeting. I'm in hometown itself. That means home base.
Oh, okay. I thought you were in a car or something.
Yeah. I'm just driving, but I'm good to take part. Don't worry.
Sure, sir. Sure, sir. I think probably the first case and Jitendra sir can take the lead for the first one. By the
Yeah, no
time you'll
problem.
be, yeah,
There'll be no compromise. Don't worry. So,
I don't expect it
so
also.
yeah, good to see so many young people on a Sunday evening. Dr. Gill and the other presenters.
Paras.
Paras,
So
yeah.
yeah, Dr. Paras.
I
So
hope the
Thank you, sir.
participation improves.
yeah.
Usually it is in the range of 70.
70 to 80,
Right,
yeah.
right, right, right.
So,
Prashant,
so
hi.
Hello,
yeah.
sir.
Hi. So I think probably because we were having an NSI foundation course also. Is
Yeah,
that
sir.
correct?
Bhopal.
Yeah. So
Oh,
plus there was
currently going
yesterday.
on.
That's right. Also a webinar and also the pedicon. I think the
Indus Pincon.
Indespian. Yeah,
Midterm, yeah.
Indespian. Yeah,
In
that's right.
Delhi.
That's right. Yeah. So everything together, I think a good amount of academics. So those who are not in all these are here.
Sir, midterm is over. I also came back yesterday from it.
Oh,
And
okay,
AIMS
okay.
Bhopal also got over yesterday. So
Right,
actually
right, right.
nothing right now. As of now, we are completely free.
That's great. Very good.
So, so we'll just start at
Sure.
five or something. Just we'll wait for 2, 3
Yeah.
minutes.
That should be good. That should
Sure,
be
sir.
good.
I think Dr. Gill has joined first, so she'll go ahead first. And
Right.
Paras can present second.
Yes, sir. We can start. 2 minutes to go.
Yeah.
Right.
So the format, just for everyone, it is that if Dr. Gill is presenting, the questions for the presentation itself will be directed towards Dr. Gill, but the subject matter questions will be directed towards Dr. Paras. For example, if she's presenting on vestibular schwannomas, for example, so if she has not taken some kind of history or the examination seems incomplete or there are some signs that she has missed, the marks or questions will be directed towards herself. But if there is a theoretical question related to this, as on why did step down hearing loss occur, or what is recruitment, or something like that, those will be directed towards Paras, because most probably Dr. Paras must have prepared his own case, but we are testing for residual knowledge, right? So that is the idea, so that they in the exam they won't know what is coming. So yeah, and there'll be OSCEs which we'll project.
Dr. Paras, I think it's 5 o'clock. So if it's okay, then if the moderators are also okay, Harsh,
Sure, sir. We'll
can we get
start, sir.
started?
Yeah,
Yeah.
Dr. Gill, are you there?
Yes, sir.
Yeah, please go ahead. Please share your PPT and then you can start presenting.
So from the
The share button is at the bottom, the fourth one from the right.
yes, sir. Think it's not getting.
Okay, by the time, otherwise, Paras, you can start if your thing is loading.
So just to tell a quick point,
Sure.
as Dr. Gill was having some
Okay.
difficulty in sharing in the exam, what I would advise all our residents and our examinees is that try to get very familiar with your history, that you don't have to refer to the notes when you present to the examiner. So that helps to get a better rapport, establish eye contact with the examiner as well. But definitely to frame your thoughts and to give it some directions, always write, good to have it written down, but get so familiar with it that especially for long cases, try to see if you can present without consulting your notes too often. Okay, so that is just a quick point while we're getting ready.
Is it sir?
Good evening, sir. Is
Yeah,
I'm
go ahead.
sir,
Good evening,
screen shared or not?
Visible.
Should I start the presentation?
Yeah, just make it full screen. Please start.
Sure, sir. Good evening, everyone. I'm presenting the case of Mr. XYZ, 31-year-old male, right-handed, resident of Haridwar, Uttarakhand, 12th pass. History is narrated by himself and his brother, which is reliable. The chief complaints: decreased hearing in the left ear for the 1 year, numbness over the left side of the face for 8 months, imbalance while walking for 4 months, and headache with a blurring of vision for 3 months. Decreased hearing in the left ear for the 1 year. The patient was asymptomatic 1 year back when he noticed decreased hearing in the left ear, which was insidious in onset, gradually progressive. He noticed when he had difficulty in listening to phone and listening to music using headphones on the left ear. And currently he is unable to hear from the left ear. And he was able to hear the sounds, but has difficulty in understanding the words. And it is also associated with while watching the television for the longer duration, need to gradually increase the volume of the television to hear, and subsequently he started watching TV at the high volume settings, which was uncomfortable for him. No history of ear discharge, tinnitus, earache, or any trauma to the ear. There was no history of any sudden exposure to the loud sound, no history of improvement in hearing while in the crowded places, no history of any sudden increase in the loudness of the voice while increasing the volume of the television, no history of any long-term medications which was taken by him, and no history of any decreased hearing or similar complaints in the right ear. Numbness over the left side of the face for the 8 months, which was insidious in onset, dull, continuous numbness over the left side of the face, mild intensity, and he was also having the feeling of heaviness over the left side of the face. That was from the angle of mouth to forehead, and there was no history of sharp shooting or electric shock like facial pain, no altered perception of the touch sensation over the face, including the hot and cold while washing the face, and there was no history of any fall, and no history of any frequent redness of the left eye, no difficulty in mastication while chewing on the right side and the left side, no pain during mastication, and no difficulty in opening the mouth, no deviation of the jaw on mouth opening, and no similar complaints of the right side of the face. Imbalance while walking. He was also complaining of the imbalance while walking for the 4 months, which was insidious in onset with a gradual progression, swaying towards the left side of the body while walking. There was no change in the symptoms during the daytime, nighttime, or in the dark environment, or during the washing the face. On the closure of the eyes, no history of falls while walking or daily routine activities. There was no associated vertigo, dizziness, or the tinnitus. No history of any speech difficulties. No history of stiffness or the weakness in any of the limbs. No history of any tremors. Headache. The patient was also complaining of headache for the last 3 months, which was insidious onset, intermittent, occurring on and off, dull aching time, mild to moderate intensity. Initially, it was bifrontal and later become holocranial, associated with episodes of the blurring of the vision without any diplopia, and relieved with the medication and occasionally subsided on its own. No aggravating or the relieving factors, no diurnal variation in head severity. The headache was also associated with the intermittent and the projectile vomiting episodes, which was associated with the nausea, and the headache was relieved in the morning, and the headache was also relieved after the vomiting episodes. Associated symptoms: no change in the voice, difficulty in the swallowing, no history of any regurgitation, no change in the or decrease in the smell sensation, no visual disturbances such as diplopia or the diminished vision, no drooping of the eyelid, abnormal deviation of the eyeball, and no history of any seizures, no history of any memory disturbances, no history of any dark or light patches over the body. So should I continue?
No, wait. So can you just go to your first symptom? Slide of the first symptom. There was reduced hearing or hearing loss, something for 1 year.
Yes, sir.
Yeah. So the question to Dr. Paras, what do you think this is? Where do you localize this symptom?
The patient is having difficulty in listening to phone and music. So probably a high frequency sound is involved. So I
What
would
other
like to
history?
say
What other history you can take to, like? What do you want to? Do you suggest anything can be added in this history taking to make it more into the high frequency which you use the word? And the second last point of associated with while watching of the television with longer duration need to gradually increase to volume of television to hear, and subsequently he started watching TV at high volume settings, which he was not comfortable with, or something you told Dr. Gill. So do
Yes.
you want to? What was that? Can you repeat it to Dr. Paras once?
That was associated with while watching of the television for the longer duration. And subsequently, he has to increase the volume of the television to hear, and
Yes,
he started watching television at a high volume settings,
which he was
so was
comfortable
he
with, or which he.
comfortably hearing it.
Okay, next slide. So what do you understand, Dr. Paras? Why this history was important? No history of sudden exposure to loud sound.
sir, it is suggestive of rollover phenomena, sir.
What phenomenon?
No, sorry, sir. No history of recruitment phenomena, sir.
Is it
Sudden
history or
sorry, sir.
see what is the difference between first point and the third point?
No history. Sir, first point is suggestive of that he was not able to hear the loud sound.
Is it
And
so?
second point is yes, sir.
No,
And
I'm
second point suggestive of sorry,
not
sir.
second, third. I'm asking about third point. There
Sir,
was no.
third point is yes, sir. Third point is suggestive of recruitment phenomena, sir.
Okay. Do you agree, Dr. Gill? Do you agree with these 2 points with Dr. Paras, especially first one?
Yes, sir. In the sudden exposure to the loud sound, the patient was unable. मतलब कि there was no history of that thing. कि whenever he volumes at high volume, he was able to.
I think this is this the past history, or is it the history of sudden, like, perception of a normal sound as a very high, that covers into the third point. But this first point of no history of sudden exposure to loud sound, why do you ask this, Dr. Gill?
To rule out this conductive hearing loss, कि if the patient.
Yes. So this was the difference, not rollover or third point. I agree
Okay.
for it goes. So Dr. Paras, where do you
Because
localize, again coming to the same question, where do you localize this lesion? What was there in the history which made you to label it as a high frequency? You
the
can
first
see
is
the.
he was having difficulty in listening through phone, sir, and music. That is suggestive of high frequency loss, sir.
So
And
what
there
are
is
the high
a
frequency sounds? What are the high frequency sounds? Mobile phone is a high frequency sound, or television. These are the only two sounds mentioned in the history. What Dr. Gill could have taken further, like what other sounds could have been asked from the patient? Do you want to add anything, Dr. Paras?
sir, history of uh, bell sounds, ringing bell, and history of cooker, pressure cooker voice,
So, Dr. Gill, did you ask these
and any
questions
female
with
voices and crying of baby.
yes, and then bus horns, trains, especially these are
Bus
very
on, yes, yes, sir.
typically, yeah. Have you asked
Yes, sir.
all these questions to make it high frequency? Just one thing of mobile phone doesn't go into the high frequency. So we cannot make out what kind of hearing loss.
Okay.
And then what in this particular slide, what is most important symptom, which is not there in this patient particularly, where usually you localize this as retrocochlear or sensorineural, at least sensorineural. What kind of hearing loss is this, Paras?
Sensory neural type, sir.
Why do you say so?
Sir, according to 4 points, sir, I can understand it is history of tone decay, sir.
Where is the tone decay history? Like patient will not say there is a tone decay with me with my hearing loss.
Because
Yeah.
because he was increasing the volume of television in a subsequent over the time, sir. And after that, after a certain point, he started watching television at higher volume. So
Yes,
it is
and then
suggestive
there
of
were
tone decay.
yes, and then multiple negative history was also there, which she ruled out
No
from
history of ear
for
discharge also
conductive
that
loss.
that yes, sir.
Are you seeing
That
any word? Are you seeing any
conducting
word
loss.
in this slide which could have been there, especially in the beginning of the symptoms?
So that history of ring, buzz, and everything, sir. That will history
You
of higher
said it's
frequency loss, sir. And
plus.
history of this thing is history of improved hearing in crowded place, sir.
What happens usually when tinnitus? Usually it is there or not there in sensory neural hearing loss?
It is there, sir, but it disappear after the progression of disease, sir.
Yes, but you have to ask it properly. So even if Dr. Gill could have mentioned that there is no history of tinnitus even in the beginning of the disease or even in the beginning of the symptoms, you have to remember, see, this is everybody will go into finally some lesion which will come to know. But tinnitus is a very important symptom, especially in the beginning of the
Yes.
onset of the disease,
Disease.
and then the hair
Beginning of
cells
disease.
die and then this symptom disappear. So if you
Yes,
make an effort to mention it that it is not there or was there, so it makes examiner like understand that you know how the physiology turns into pathology and finally it disappears.
Yes, sir.
yes, sir.
Paras, you have to remember this. Okay, then next go further.
Yeah, can I add
Okay,
one
sir.
point
Yes,
here,
sir, please carry
Jitendra?
on.
Yeah. So I think unilateral hearing loss was the main symptom, and some terms we had used like recruitment, rollover, and all. So can I just ask in simple words, how do you differentiate between a conductive hearing loss and a sensory neural hearing loss? And then the second part of the question is, in sensory neural, how do you differentiate between the
Cochlear and retro.
cochlear and retrocochlear? And can you explain your answer based on that is this phenomenon of recruitment, tone decay, rollover, as speech discrimination? Can you use these words while you explain your answer? Paras
Okay.
and Dr. Shiv Gill, any one of you can go at the question.
So to differentiate between the conductive and the sensorineural hearing loss, first is the patient can hear the better in the noisy surroundings. That will lead to the conductive, and then to differentiate between the sensorineural hearing loss, whether it is a cochlear, retrocochlear. Here's the recruitment and the rollover phenomena comes in with the patient. If on the high volume settings, the patient is able to hear the sounds.
Hear the sounds or is it sudden loud
Sudden loud.
perception
He feels like sudden
perception
loud,
of
the
yeah.
perception of the sound.
In case of cochlear or retrocochlear?
The retrocochlear.
Paras, you want to go ahead with this answer or you want to?
No, sir. It is cochlear, sir.
Why?
Sir, because of damage of long hair cell, sir.
Outer hair.
There is sudden stimulation of long hair cell that will cause the recruitment phenomenon.
It is a
Sorry.
it's a cochlear.
Cochlear.
Yes, sir.
The
Cochlear.
upper hair cells are damaged and then the inner hair cells get stimulated on the high frequency.
Perfect. Okay. Any other point, Paras, you want to add?
So he has given ear discharge, ear trauma history, sir. That's ruled out conducting hearing, and that he has given also paracusis, speech,
These are
mouth
only
branding.
incidental,
Sorry, sir?
incidental parts of the history. So the main point is, Paras, the main thing is that when the simplest way to put this answer is when you have conductive hearing loss, it is a uniform hearing loss across all frequencies. In other words, you hear, the intensity of sound is affected. It is not the frequency. So
Yes,
the
sir.
intensity of sound across all frequencies, you hear less. While you correctly put the answer for sensory neural is that it is particularly directed towards the a
High
particular
frequency.
frequency, and
Yes, sir.
your recruitment phenomenon proves that. Now, how do you differentiate on history between cochlear and retrocochlear?
Sir, one is on the basis of recruitment phenomena, like
Okay.
it
So what is the
normal person.
what is the physiological basis of the what is the physiological basis of recruitment phenomena and other phenomena which are used in retrocochlear?
So because due to damage
So
of
I
outer
agree
hairs,
that recruitment, yeah, recruitment is a phenomenon associated with cochlear deafness. And what
yes,
is
sir.
the
Sorry, sir.
You got muted in between.
Yes, sir.
Your sir.
no? What is the physiological basis of the recruitment phenomenon? I know you said that it is a feature of the cochlear deafness.
So due to damage of outer hair cell. Hello, sir.
Yeah, continue.
Hello, sir. Due
Continue.
to damage of
Yeah, yeah.
due to
So damage of outer hair cells.
initially it will not perceive the sound intensity, and suddenly after a certain threshold it will suddenly perceive the signals sound intensity, sir. So there will be sudden
No. See,
perception
it's
of
not
loudness.
intensity. It's not intensity. See, there is
It
a
is
tonotopic organization of the hair cells in the cochlea. So certain frequencies, certain stimulate a certain area of the cochlear hair cells. So it is not the intensity, it is the frequency. So small changes in frequency can be perceived as very abnormal changes, and that is the physiological because of certain loss of outer hair cells, as you correctly put it. Okay, so that is a phenomenon of recruitment characteristic of cochlear deafness. Now, what about retrocochlear?
then in retrocochlear there will be history of tone decay, there will be history of rollover phenomena. In tone decay, we used to in pure tone audiometry we used to give intensity, like we start from the 40 decibel. After a certain time he will not listen, then we'll start intensity at 45 decibel, then he will listen. After a certain point he will not listen, then again we'll increase the intensity. So he will hear. That is suggestive of tone decay, sir. That in case of television history he has mentioned, sir. Hello, sir.
Yeah. So Dr. Gill, do
Yeah,
you
that's
agree with
fine. Go ahead. Go ahead. That's fine. Go ahead.
And second is rollover phenomena, sir. In case of rollover phenomena, we increase the intensity of sound, sir. So uh, after certain point, initially will the hearing will improve, but after certain point, he will be intolerant to the hearing, sir. Patient will intolerant to the sound, and there will be decreased speech discrimination also.
Right, that's fine. So, loss of speech discrimination, making out the quality of words is one of the characteristic features of a retrocochlear deafness.
Retrocopy.
Okay, that's fine. Yeah, you put it right. Fine.
Thank you, sir.
Okay, carry on. Next. So this symptom, Paras, can you explain this? Like where do you localize, or what do you understand by this symptom of 8 months duration in this case?
So it is suggestive of involvement of sensory component of fifth nerve, sir.
Okay. Okay. Dr. Gill, you can continue with where you left, and then we'll discuss at the end where the localization goes. So there is no significant past and
No
these kind of.
significant, yes, sir. No significant past and personal history. With the
Mhm.
family is no significant family history of any neurological diseases, malignancy, or any hereditary illnesses. And to summarize my case history, a 31-year-old right-handed gentleman with the complaints of decreased hearing in the left ear, sensorineural hearing loss with the numbness of the left side of the face, followed by imbalance while walking and swaying towards the left side with the raised features of the ICP. Substrates involved based on the history are the left
Okay. Let Dr. Paras localize this lesion or wherever like these symptoms. Can you analyze the history, Paras, with what are the substrates involved and where is the lesion?
Sir, because of there is a history of uh, recruitment phenomena, there is no recruitment phenomena,
No,
and
we
there is a
have
history of
this,
tone decay.
that hearing loss we have gone into, like there is a unilateral
Yes, sir.
high frequency retrocochlear sort of sensory loss on the
Yes,
left
sir.
side. Okay, so this is what does it indicate to you? Where do you localize this? Which nerve is involved?
Retrocochlear.
So eighth nerve. Okay,
Retrocochlear.
vestibulocochlear. And then what was the next symptom?
Numbness of the left side of the face, sir, which is history of sensory component of sixth nerve.
Okay.
and there is issue of imbalance while walking, and there is swaying toward the left side. I will localize this symptoms toward the cerebellum or middle cerebral peduncles. And there
Okay.
is issue of raised ICP headache also, sir.
Why do you say there is a raised ICP of feature, a raised ICP type of headache? What made in the history to make you say like this?
So initially it was the frontal headache, sir. Then later the character of headache changed to the holocranial.
It was
And there
bifrontal
is issue.
and then changed to holocranial, but there was no
Yes, sir.
diurnal variation.
Yes, sir. But still there is issue of improvement of headache after vomiting, sir, which
Why?
favors toward the.
Why it happens?
Sir, it happens because after vomiting there is CO2 wash out that will lead to the vasoconstriction, and there is one more
Slight
reason is
reduction in ICP.
dehydration. Sorry, sir.
Yeah, slight reduction in ICP. Okay, then
Yeah.
which nucleus of the fifth nerve do you think involved in this? Or is there where in the fifth nerve is the involvement?
In the cisternal
Can you go to
spaces, sir.
the Dr. Gill? Can you go to the symptom of fifth nerve? There is a reduced sensation or what? Numbness. Yes,
Reducing.
numbness over the left side of the face for 8 months. So, how many nuclei are there for fifth nerve?
So there are 3 sensory nuclei and 1 motor nuclei, sir.
3 sensory and 1 motor. Okay, so where this numbness over the left side of the face is through which of the nucleus?
Chief sensory nucleus of.
Is it a nuclear lesion or a cisternal segment involvement of the fifth nerve or what? Where do you localize it first of all? That was a theoretical question mostly, but
Sir, it is as it is ipsilateral symptom is ipsilateral to the disease, sir. I would localize to the cisternal spaces.
yeah, fifth nerve where? Fifth is too long, na? So nuclear, extranuclear, and then cisternal or Michel's cave into the cavern. Where is the localization? Other foramens.
Cisternal, sir. Cisternal spaces.
Why?
Okay, Paras, sorry to interrupt. Okay, can you just tell us what are the nuclei of the fifth nerve and where they are located? All the nuclei.
So first is mesencephalic nucleus, sir. That is located in the midbrain, sir. Second is chief sensory nucleus. That is located in pons. And third is the third sensory nucleus, the spinal nucleus. That is located from the lower pons to the C4 of the cervical cord. And
Where?
there's motor nucleus.
C4.
Motor nucleus that is located in the pons.
So general sensation over the face is through which nucleus? Mesencephalic.
The chief sensory nucleus, that mesencephalic nucleus carries the proprioception, sir.
Mesencephalic carries the proprioception.
Yes, sir.
Yes, okay. Good. And then chief sensory nucleus, general sensation. This sensation must be going through, which is impaired in this patient, will be through which nucleus?
Chief sensory
Chief
nucleus, sir.
sensory nucleus. Good. Located in midbrain, midpons.
Pons.
Midpons. Okay. Good. So this is a cisternal involvement, you think, because there is no other lesions of the fifth nerve where in the rest of the foramen or Michel's case. So cisternal involvement of the fifth nerve with eighth. So what are the okay, come to that localization slide. Yes. What pathology do you suspect, Paras?
Sir, initially there is involvement of hearing, sir, followed by the fifth nerve involvement, and followed by the cerebellum. I would localize this region into the CP angle region, sir.
Okay. And why there is raised ICP? What pathology can be there? Most common pathology in left CP or CP angle.
Most common pathology in CP angle is vestibular sonoma, sir.
Good. Then second differential.
Second is meningioma. Third is epidermoid. But epidermoid usually does not cause raised ICP, so I would not like to prefer toward the epidermoid.
But there is irritative
Paras,
symptoms. Yes, sir.
Paras, I want to interrupt
Sorry,
you.
yes, sir.
I
Sorry, sir.
have a different localization. Okay, so my localization is this is a Petrus lesion. Okay, this is a Petrus lesion which is exophytic into the CP angle or just purely Petrus lesion. That explains everything: your hearing loss, your fifth nerve involvement, everything. So, do you agree or disagree?
But hearing will not
disagree,
involve
why?
in Petrus lesion.
Why hearing on there? Your
But
cochlea is inside the Petrus.
But
And
initial
we are not sure
symptom,
on
yes, sir.
history. On history, you can never be sure whether it is conductive or sensory neural. So that possibility definitely can be kept in mind.
Okay, sir. Yes, sir.
No, you can disagree. You're free to disagree, but you have to give me strong points for disagreement. So it could be purely petrous, or it could be a petrous lesion which is exophytic into the CP angle, which is extending into the CP angle.
Sir, according to me, sir, it is CP angle lesion which is extending up to the petrous region, sir.
No, everything is okay, but you have to give strong points to disagree with me.
Are you,
Just because we see CP angle, just because we see vestibular schwannomas more commonly than petrous lesion, it doesn't mean that you disagree with me. You have to give me strong points for disagreement, or you can leave it for your examination.
Sir, I will answer after examination, sir.
Okay, so we'll
Hello,
look at it after you examine. Yeah, that's fine.
Oh, okay, sir.
you can continue, Dr. Gill.
One more point is that, could this be an intrinsic brainstem lesion which is also exophytic into CP angle,
Okay.
which can also masquerade like a CP angle lesion? Is that possibility there?
Yes.
Yes, sir, it would be there, but there is no,
Involvement.
as of now, there is no ocular features here, and there is no
What
issue of
features of,
weakness. There is no tract sign.
Okay, what are those features which are
yes,
considered sine qua non of a brainstem lesion?
yes. Indirectly, the question is, what are the intrinsic brainstem lesion features, which is there in this case or not there? You can just justify like that.
Sir, there could be history of diplopia in the brainstem pathology, sir, and there will be a tract sign involvement of weakness will be there, sir.
Okay, you said
Next
may not always be there. Those sine qua non features, okay, as part of a internuclear ophthalmoplegia, you might
Yeah,
have diplopia. Okay, then you don't have long track signs. But sometimes some of the exophytic brainstem lesions could have very, very subtle. They may not have brainstem nuclear involvement, or INO due to a intrinsic brainstem involvement. They may be just purely exophytic into CP angle. Okay, some small cystic dorsal. So it is still a possibility. So you have to think of at the end of history all possibilities, not just a CP angle schwannoma which you most commonly see. Okay, we can always look at it further on the examination.
Okay, sir.
So,
Okay.
Paras, you rightly mentioned there is no diplopia or like other cranial nerve involvement, bilateral, and what else can be there in the intrinsic? Just for discussion, Horner syndrome also you have to see.
Honor, sir, amazing.
But as George sir has mentioned, in exophytic they may be absent also again. The
Absent also,
lesion
yes, sir.
is immediately going to the cisternal.
But sir, in this case, first symptom is the hearing loss, so I would not like to
Yes,
go
yes,
into
you
the brain.
can. It is
Yes.
like George sir is asking that you may disagree.
It could be, yes, sir. It could be,
Yes,
sir.
yes. Okay, go ahead then. We'll see after the examination.
Yes,
Yes.
sir.
Chalo.
General physical examination. The patient is moderately built, moderately nourished, conscious, alert, cooperative, oriented to time, place, person. Patient is comfortably lying on his bed. No icterus, clubbing, lymphadenopathy, pedal edema, spine normal curvature, no deformity, no swelling, face, left angle of the mouth absent with this absent wrinkling over the forehead, side of the forehead, no evidence of the redness in the eye, no neurocutaneous markers were present over the body. All the vitals pulse 60 beats per minute, regular. Respiratory rate 16 per minute with thoracoabdominal, and the blood pressure 130/90 millimeter mercury in supine, taken in the supine position. The temperature is normal. Higher mental functions were normal, and with the speech fluent, repetition present, comprehension is present, and the appearance and the behavior were appropriate.
It's 17:30.
Cranial nerve examination. Olfactory examination was normal. Optic nerve, visual acuity 6/6 in both the eyes, with the pupils 3 mm reacting to light. Both the direct and consensual reflex were present, and the color vision no impairment. And on fundoscopy, grade 5 papilledema was present, and the oculomotor trochlear and abducens nerve, extraocular movements were normal, with the bilateral pupils normal size. Nystagmus, slow jerky movements were present on the left side with a fast component on the right side. On the trigeminal nerve examination, on the inspection, on no temporal halving. On the opening jaw, side to side movements were normal in both the sides. Motor clenching was normal, and on the both the side at the masseter and temporal temporalis, and the sensory examination, that was decreased sensation to touch, pain over the V1, V2, and V3 segments of the face, with the corneal reflex absent on the left side. Jaw jerk were absent. On the facial nerve examination, the inspection, right side inspection was normal, with the left side wrinkling of the forehead was absent, with the bilateral complete eye closure present, obliteration of the left uh, nasolabial fold, with the angle of mouth deviated towards the right side. On asking the patient to show his teeth, House Brackman grade 3. On the palpation, the bilateral platysma was prominent, with no leakage of air during the puffing cheek test, and the corner reflex was absent. Taste was normal. On the vestibulocochlear nerve examination, the whisper test was done, which was normal on the right ear and absent on the left ear. With the finger rub test was absent on the left ear. Rene test where air conduction was better than the bone conduction. And the Weber test that was done, and it was lateralized to the right ear. Schwabach test, bone conduction less than the air conduction. Bone conduction is less as compared to mine, and calorie test was not done. The 9th, 10th, and the 11th, 12th nerves were normal. In the motor examination, was normal in both the sides. With the sensory examination was also on the normal on the both the sides by doing the fine touch, vibration, and joint sense. With the spinothalamic column, pain and temperature, cortical sensations was also intact. On the cerebellar signs, while doing the examination, gait ataxia was present. That was the broad base ataxic grade with a tendency to sway towards the left side while walking. And the nystagmus was also present with the core symptom with a fast sway towards the right side and the slow component and the jerky component towards the left side. Intention tremors were present. This diadochokinesia was present on the left side, and the finger nose test was unable to perform. With the heel knee test, couldn't perform on the left side. Pendular jerk was absent, and the tandem gait he was unable to perform. Meningeal signs are absent. And on the other examination, system examination was normal. Cardiovascular, respiratory, and abdominal. And on summarizing the history, 31-year-old right-handed gentleman with the complaints of decreased hearing loss, sensory hearing loss with the numbness of the face followed by imbalance while walking, and with the gaze evoked nystagmus and broad-based gait with all cerebral signs positive on the left side with the raised features of the ICP. My probable diagnosis is vestibular schwannoma, then meningioma, epidermoid metastasis.
Okay, Dr. Gill. I want to ask Paras. Paras, are you there? I'm not able to see Paras.
Paras, can you switch on your video, please?
Okay.
Has he logged out?
Okay, till Paras comes on, I want to ask a few questions to Dr. Shivgil. One is that, see, in your history, there was no mention about, because this is a long case, there was no mention about anything about a negative or positive history about higher mental function examination. Do you think it is significant in this case? Because we have a young male with a unilateral hearing loss. So, do you think higher mental function examination, at least some negative history would have been important in a I think some general things you told, but it was not in a structured manner. You said that no memory disturbance, everything. So I think I am asking this question a little late, but a little structured higher mental function examination, other than memory. Okay, personality changes or a little more detailed structured exam mention is important. Why do you think it is important?
So as the glioma can also be there, accessory tumors that will lead towards the if any accessory disorders to
As part of
neurofibromatosis
okay, as
rule out.
which neurofibromatosis? You have to be very, very specific in your answer.
Neurofibromatosis, so 2.
No, why only two? It could be part of neurofibromatosis part 1. Unilateral vestibular schwannoma may be part of neurofibromatosis type 1. Okay, and not gliomas, more than gliomas, it's common to have olfactory groove. So synchronous multiple lesions sometimes are picked up just on higher mental function examination. Okay, so that's why a negative history is very important. In your physical examination, especially some of it was a little sketchy. Eighth nerve examination, you mentioned eighth nerve has two components, vestibular and cochlear. So you mentioned some tests for cochlear like the Rene's test and the Weber's test. What about tests for vestibular function? What are the tests for vestibular function? Specific tests?
Walking, star walking.
Yeah, the Fukuda test, star walking test. Have you heard of that?
Yes, sir.
So perhaps you should have also mentioned that, right?
Ji, sir.
And your nystagmus also was a
Yes.
little incomplete. It was a little sketchy.
Yeah.
So what type of nystagmus? Can you tell us what is nystagmus and enumerate this nystagmus a little more better? If you have some clinical photographs, we can see that. Otherwise, it's fine, no problem.
Yeah, I wanted to ask same thing also. Like nystagmus, you have mentioned about that it is a right side, right deviated or something. But what was there in the neutral position? Was it a gaze evoked nystagmus? Was there the bilateral? What kind of nystagmus? It was very poorly mentioned, honestly.
It was gaze evoked nystagmus, and the
You mentioned it in one of the slides, but during description it was not clear. So I wanted to ask the same question to Paras because in your case, Paras will be responder. That's why. But he was so Paras, have you listened to the history physical examination completely in this case?
Sir, sir, some part I got disconnected, sir.
Yeah, there was
But
a
I,
technical difficulty. I got to know.
yes, sir.
Okay. So you can go to Dr. Gill. You can just mention the slide of that examination of okay, cranial nerve. Then cerebellar signs you can come where the nystagmus was mentioned. Okay, just show to him. He has not seen anything. I think trigeminal you can start. Kilometers. Or you can quickly within 1 minute, Dr. Gill, you can mention the positive findings so that he is aware of what is the extra we got after the examination.
in
Yes, sir, we have time.
So you can, should we, like, can she repeat it? If
Yeah,
time
please go ahead. Repeat.
Okay,
Yes, sir,
go
please,
ahead.
please.
Go ahead then.
the positive history that there is the grade 5 papilledema was present, no optic nerve any involvement of there. In the trigeminal, the sensory examination was positive with the decreased sensation to the pain and touch, with the corneal reflex absent and the Georgic was absent. And on the facial nerve, that was the House Brackman grade 3 was present with the bilateral platisma was prominent with the no leakage of air from during the puffing cheek test with the corneal reflex absent. And the normal on the vestibulocochlear nerve, the whisper test was absent on the left ear with the finger rub test was also absent with the Renius is air conduction better than the bone conduction, and the in the Schwabach test the bone conduction was less as compared to mine, and the calorie test was not done, and the rest of the nerves were normal. In the cerebellar signs were also positive, which was showing the this diadokinesia was present with the gait ataxia, broad-based gait, and the tendency to sway towards the left side. And nystagmus, the slow component was on the left side as compared to the fast component towards the right side, with the intention tremors present, and the finger nose test and the heel shin test was not couldn't be able to perform, with the pendular knee jerk absent and tendon gait was unable to perform by the patient.
So Paras, when we were absent, this is how like we reached up to this point. Do you
Yes,
agree?
sir.
Like, can you analyze after physical examination, like what extra was added, and was the history points on the history or corroborative with the physical examination? Can you summarize it, Paras?
Yes, sir. In the final
After physical
there, sir.
examination, what was the new thing added to the local to the substrates involved?
Sir, she
Not
has mentioned about the ataxia, sir, and one more thing is facial nerve weakness. He has mentioned.
yes. So new thing added is seventh nerve.
Yes, sir.
Okay, left side.
Um,
Then
yes, sir. And nystagmus he has mentioned it is not there in the history, sir.
okay.
And he about the gate also that is not mentioned in the history.
No,
No,
that
but
was
imbalance was there.
And
Gait imbalance was there. Now already symptom.
new
Do you want to?
symptoms.
Okay. Just summarize what are the substrates involved finally. After the examination, what are the substrates involved in this patient? Paras. Quickly you do.
Okay, sir. Left side, eight nerve, sir.
Yes.
Bilateral optic nerve involved, sir, because of raised ICP.
Okay, then.
Left cerebellar peduncles, or cerebellum is involved, and the left side element, seventh nerve weakness is there, sir. And that is also left side fifth nerve involved, sir.
Left side?
Fifth cranial nerve, sir. Trigemin.
Fifth is already there. Okay. So where do you like, do you want to change the localization or the pathology, or you want to go ahead with the same?
We'll go it with the same, sir.
You are still not including petrous apex lesion, which was like suggested to you.
No, sir.
Instead of metastasis also in a 31-year-old.
So Paris, your differential diagnosis list is very short and highly biased by, I think, few vestibular schwannomas which are more commonly seen in neurosurgical practice. So you have to think laterally and expand your differential diagnosis list. And again, the provisional diagnosis which you have given, vestibular schwannoma, okay, but schwannomas are a spectrum. There are so many other nerves in the
Yeah.
CP. You have to say the entire spectrum of schwannomas. Okay, commonest maybe on epidemiological profile wise, maybe your vestibular schwannoma is the commonest lesion. Maybe we can accept. And then what do you mean by meningioma? Meningioma is such a vague term. You have to be specific. Which are the meningiomas which are actually seen in the CP angle and which can have such a presentation? A question is to both Paras and to Dr. Shiv.
This list is provided, sir, by Dr. Gill. So Paras was given a chance to expand the list, but he has not responded. Like he wants to go ahead with a vestibular schwannoma itself. So now the question is open to both of them. Do you want to expand it, change it, modify it?
So the first, the vestibular schwannoma, second meningioma, epidermoid. It can be
No,
the
What
meningioma. You have
meningioma?
already given the what meningioma? What are
pericallus,
the
petroclival meningioma.
Okay,
yes,
one possibility
petroclival?
petroclival. Okay, then again it becomes petroclival means your localization becomes very huge. Okay,
Yes.
sphenopetroclival.
Which nerve
Okay,
is not, which nerve you should always have to have a petroclival meningioma to have, or a patient of a CP angle has to have that nerve to tell you that there is a brainstem rotation or there is a petrous apex or clival involvement. Which nerve is that? Is it there in your history?
No, sir.
So what is that nerve? Not no. It means there are so many nerves which are not there. Which nerve?
So third and fourth.
No.
Sorry.
Paras, you want to take a chance on this?
Sixth nerve.
Sorry?
Sixth nerve, sir.
Yes,
Everything.
sixth nerve. Chef, this will be the sixth nerve. You have to have that sixth nerve involvement.
Yes, sir.
Okay. So, I mean, George sir is leading you to other differentials. You have to defend. It is your case. You
Sir,
know
it could
that.
be it could be fifth nerve sonoma or seventh nerve sonoma also, sir.
Yes, I was going to that part. Why it is not a trigeminal schwannoma?
Sir, if it is trigeminal sonoma, first it involve the conducting loss will be there, sir, because bone conduction will get hampered
No,
first, sir.
but you only told that it could be trigeminal schwannoma. I am denying it. It is not trigeminal schwannoma. What point is there or significant positive that significant history is not there for me to say you confidently it is not trigeminal.
Sir, there is no history of facial pain, sir.
Facial pain.
Facial pain, and there is no history of motor weakness of fifth nerve, sir.
Motor weakness, she has already told so many times. Multiple times she has told you there was no history of atrophy of the
Motor weakness.
mastication, there was no difficulty. And then radicular, again, sensitive, although less common, morely there will be paresthesia or numbness only,
Yes, sir.
which is actually there, but only after involvement of vestibulocochlear nerve or the sensory neural hearing loss for 1 year. Okay, then maybe third or fourth you can go for trigeminal, but not in the second one. Then meningioma. What meningioma? CP angle meningioma.
Yes, sir.
Historically, what made you to like rule out meningioma?
Paras, if you don't know, you can go ahead.
Sorry,
Just
sir.
say don't
And the
know.
question will be passed to Dr.
Yeah,
Gill. He can
yeah.
answer.
Yeah.
So for the meningioma, the first will be involvement of the seventh nerve.
Yes, there will be earlier involvement of seventh nerve. And what kind of headache she had or he had?
So occipital or the frontal.
Bifrontal. Dural involvement in the
Headache.
posterior fossa will have different kind of headache pattern to start with. Obviously, this seventh nerve is a major answer. Okay. Why it is not epidermoid?
So
There will be. Hello, sir.
Yeah, either one, please.
So there will be irritative features in case of epidermoid, and there will be the raised IGP feature is very last time in the epidermoid, sir.
multiple cranial nerve involvement will be there in the epidermoid.
Yes, irritative symptoms will be there, as you mentioned. There will be more kind of trigeminal neuralgia sort of symptoms, which is not there in your case. Metastasis,
And what else? Papilledema will be there in epidermoid.
No, sir.
No, sir. No, sir.
metastasis is completely out of question. There's no doubt. I mean, you can put whatever, but this metastasis cannot be at fourth. Why you put like metastasis?
So recently I have seen.
The 31-year-old.
CP angle metastasis can be there, but I mean that can be an exception anyway. So what? Any other addition, Paras and Gil, you want to add?
So one is the Pitrix apex lesion, and the one is calcified aneurysm, sir, the ICA aneurysm.
Yes, vascular pathologies also you can
Pathology can be
add.
there.
Something more ENT related.
Cholesterol.
So I think you have to be a little more structured in your differential diagnosis. Okay, now you have only enumerated the pure cisternal CP angle lesions. Okay, so all types of schwannomas. Again, meningioma, you said petroclival, but we are not really accepting the petroclival answer. Can you expand further? Which other meningiomas?
Tentorial meningioma, sir. But
Okay, anything else? Do you have any classification of petrous meningiomas? Are you aware of any?
Classification, yes. You're doing very good, Shivkaran and Paras. Please don't get completely mute. You just keep on talking, whatever. It may be wrong only. We
Petrus
can discuss.
meningioma class.
Okay.
yeah, sir. Classification is meant for this tentorial meningioma, sir.
Okay. So posterior petrous meningiomas, CP angle meningiomas. Okay, the term CP angle meningioma is actually not exactly a petrous meningioma. Okay, sometimes the origin may not be very clear. And then your differential diagnosis, your list has to expand, especially when you see, you imagine all the structures which are bordering around the CP angle cistern. So the lesion could be from any of those, one of which we mentioned is the petrous base or even the petrous apex. So petrous lesions, like you already got a clue from Dr. Harsh who asked for petrous lesions could be bony petrous lesions, neoplastic or inflammatory. Which inflammatory lesion are we looking for? It's presenting with hearing loss, and always your examination may not be very perfect, you know, that you can even if you have Renis positive or Renis negative, you might be having a mixed hearing loss, which is common in petrous based lesions. So can you add some more petrous lesions to this differential diagnosis list, both neoplastic and inflammatory?
Cholesteatoma, sir.
Arachnoid cyst can be there.
Yes, arachnoid
Cisternal lesion, that is in the CP angle. Okay, cholesteatomas. Then what about tumors? Petrous base bony tumors or petrous apex bony tumors?
Tell me, tell.
Chordoma.
Chordomas are usually midline, but they can be paramedian. Okay, and sixth nerve, fourth, sixth nerve is involvement is more characteristic of chordomas. But something similar to chordomas is paramedian. What is that?
Chondrosarcoma.
Chondrosarcomas. Okay, we could have giant cell tumors, we could have Ewing sarcoma. And since this is a young male, what are the neurocutaneous syndrome associated CP angle lesions? One you said is it could be vestibular schwannoma. Anything else?
The meningioma, glioma, sir.
Okay, CP angle meningiomas, but gliomas very rarely will be exophytic into CP angle. So posterior fossa gliomas or cerebellar gliomas we are not considering in the differential diagnosis. Anything else? If I tell you that this patient has, suppose if this patient had retinal angiomas, renal cysts, and has got a CP angle lesion. Anything else you want to add to this differential diagnosis? What is the neurocutaneous syndrome you are considering? If patient has got retinal angiomas, has got say renal cysts, pancreatic cysts, and has got hypertension, pheochromocytoma, and a CP angle lesion. What do you want to add to this differential diagnosis?
VHL, von Hippel-Lindau.
VHL, yeah, correct. That is the neurocutaneous syndrome. But what are the CP angle lesions associated with VHL, which can have a similar presentation in a young patient?
Meningioblastoma.
Anything else other than cerebellar hemangioblastomas are intrinsic brain lesions. So cerebellar hemangioblastomas sometimes occasionally can be exophytic into CP angle, but they don't usually present like this. Anything else?
Hemangiopericyte.
No. Have you heard of endolymphatic
Dermoid,
sac tumor? Endolymphatic sac
dermoid,
tumor.
and
Endolymphatic sac tumor
Postoperative
associated with VHL can have a similar presentation. Okay.
Can
They
choroid
arrive.
plexus yes, sir. George, sir, please.
Yeah, please, yeah. So you have to consider Petrus lesions also in your differential diagnosis list. Okay, though there are some odd features, like you are saying for sure that this is a sensorineural type of hearing loss. Okay, and other thing in Petrus lesions. Anything else in Petrus lesions? Anything which will usually be seen earlier in Petrus lesions? What are the other cranial nerves which have a intrapetrous or course inside the petrous bone? Seventh nerve involvement will be earlier. Okay, you'll have more profound seventh nerve involvement. So you have to, if the examiner puts up a counter diagnosis, you should know how to defend your diagnosis.
Yes.
Okay,
Sir,
and metastasis.
sorry to interrupt both of you. We'll have to
Yeah,
wind first case up, sir.
yeah, please, we'll do that.
We
Sure.
can go to
Okay.
the
So I just
radiology
want to
and
add
finish.
choroid
Yes.
plexus papilloma. Do you agree, Shivkaran and Paras? Do you agree choroid plexus papilloma can have these kind of symptoms?
Yes, sir. It can become into
Yes, just like you have seen metastasis, there are many people who have seen choroid plexus papilloma
420.
presenting as this. So you can keep this in mind. So next we'll go ahead further. What will you do? How will you evaluate this case, Paras? Fast. What is the next thing you will do after the examination?
Sir, first I will get the plain CT done, sir.
Plain CT done. Okay.
Okay.
Why?
Plain CT followed by MRI plain plus contrast.
That's all. You will not get audiometry done. You have to do CMRI with audiometry. Remember this answer for
Okay,
your
sir.
exam. MRI plain plus contrast with audiometry. This should be your answer for a CP angle, which is going into favor of vestibular schwannoma. No CT scan. Next, you give the follow-up question. You give the opportunity to ask the follow-up question by the examiner that will you get the CT? Then you know the answers. Jugular foramen, role of IAC, all these kind of radiological discussions we can have in other meeting. Come to the next. You got the MRI done. This is the finding. Shiv, just show the scan. And then Paras, you can just read it fast. This is the
This is
axial
the
image.
axial
Tell me
axial
fast.
detuvated. Yes, sir. Axial detuvated images. In the left CP angle region, there is axial pathology can be seen, sir, which is compressing the brainstem, and there is buckling of brain parenchyma is there, sir. And there is no hydrocephalus. The lesion is also extending into the internal acoustic, internal auditory canal, sir.
Okay. So what are the characteristics of the tumor? T2 hypo, contrast enhancing or not? This is how you should go sequentially.
Heterogeneous, sir.
Heterogeneous. This is heterogeneous. T2 heterogeneous, is it? What is happening on diffusion, restriction or not or restrictions? You have to go sequentially. Idea is for this exercise is that you learn how to read the scans. T1 axial, plain, T1 with contrast or T2 after that, and then this is how you should read it. T1 hypo, T2 hyper, enhancing on contrast, well-defined CSF clefts are seen, compression over the brainstem, fourth ventricle noted, supratentorial hydrocephalus is there or not, the lesion is extending into the internal acoustic meatus or internal auditory canal. And then so what do you, is it broad based or not? This is how you differentiate from the meningiomas. Okay, so what is happening to the supratentorial ventricular system? Is it dilated, not dilated? What is happening to the third ventricle? Comment, man, Paras, fast.
Not dilated, sir.
It is not dilated. Third ventricle is not dilated. Axial, you see the third ventricle.
Slightly dilated, sir. Slightly dilated.
It is
And temporal
dilated.
horn
It
is
is
also.
always a slit-like ventricle. Okay, it is a dilated third
Yes, sir.
ventricle. There is no doubt. Temporal horns are seen. There is hydrocephalus
Seen.
noted, but may not be severe hydrocephalus, which historically is noted as told by Shivkaran. Okay, yes or no? There was bifrontal headache, raised ICP, optic examination shows papilledema. That kind of hydrocephalus is not seen, but there may be no correlation between imaging and symptoms sometimes. But then you can concentrate on the optic nerve also in T2 sequences. Okay. So what will you do next? Okay, before we move further, this is a very large lesion. If there is a small lesion in the doubtful lesion, a radiologist has reported there is a small lesion in the canal. What sequence is ideal to look for that small lesion in the fundus or IAC?
This sequence.
Sorry?
This
CIS.
sequence.
Yes, yes. Okay. Heavily weighted T2 images
Fista.
like CIS and
What
FISTA.
is CIS, man? What is the full form of CIS?
Constructive interference.
Steady state.
Check.
Good.
Continuous
There is
accuracy.
a characteristic ice chrome appearance also, na? Ice cone appearance
Yes.
also for
Yeah.
this lesion
Yes, sir.
with a CSF cleft posteriorly. These
Yes.
all things should come from you both. Okay, come to the next. Any other slide is there? Like any other scan? No.
Different.
So what will you do, Paras? What will you do with this case? Audiometry is done and there is a high frequency sensory neural loss left side, although non-serviceable. What will you do? What is the next approach? What surgery will you do in this?
Sir, first I will take that hearing is serviceable or non-serviceable, sir.
What is the
If
definition? Like
hearing is
theoretically, what do you understand by serviceable? What should be the decibel and that SDS or speech
sir,
discrimination?
speech discrimination is up to 50%, sir.
And
More than
decibels?
50,
Loss?
more
So
than
50 days.
decibel is 50.
50-50. Yes, you can go.
Yes, sir.
Which classification is this? You know, both of you.
Gardner Robertson.
Gardner and Robertson.
I think there is a change something. Okay, you read about. Okay, then.
Right, Gardner.
So is it possible that this patient can be managed without surgery? Any sort of radiotherapy or SRS or gamma knife can help this patient?
But the SRS can be done, but lesion is quite big, sir. It looks like more than three.
Compression.
Yes, there is
More
a
than 3
compression
centimeters.
over the brainstem and fourth
Yes,
ventricle
sir.
and symptoms of raised ICP. There is no doubt
Raised
patient
ICP.
needs surgery. What surgery will you
Surgery.
do? What surgery? Middle fossa approach, what are the different kind of approaches for these tumors?
So translabyrinth, middle fossa, and the retromastoid suboccipital crinoid.
Yes, I think we can wrap up.
Yeah.
We can move on to the next case. Good, nicely done, both of you. We'll sum up in the next.
Paras, you can load your PPT.
Yes, sir.
By the time he's loading, Dr. Gill always mentions Schwabach before the other test. Okay, or Schwabach cannot be mentioned at the last one.
Ji,
And
sir.
vestibular nerves were not tested. So that is a major point which is missing.
Sorry, sir. We'll improve.
Paras, please.
Otherwise, good presentation, Dr. Gill.
Yeah.
And well answered, Dr. Paras.
Yes, sir. Is it visible now, sir?
Yeah, make it full screen.
Yes,
Please.
we can see.
Just press play. Yeah.
I'm presenting a case of 56-year-old male. Mrs. Rita,
Paras,
right?
can you press play?
It's keynote, the top fourth. Yeah, fourth one. Yeah. That play. Yeah. that
Sorry,
one.
sir. Yes, sir.
Yeah, good.
One second. I'm presenting a case of 56-year-old female, Mrs. Rita, right-handed, housewife by occupation, resident of Riva district, educated till 8th class. She can speak and understand Hindi. History given by self and is reliable. These are the chief complaints: neck pain since 1 year, burning sensation all over the body since 11 months, decreased feeling of hot and cold sensation in the right of the body. Sorry, sir. Right of the body since 9 months, stiffness of the right upper limb and lower limb since 7 months, gradually progressive weakness of all 4 limbs since 6 months. 1 second, sir. I want to minimize this. Sir. Mhm. 1 second, sir. My patient was apparently all right 1 year back. Then she developed neck pain, which was insidious in onset and gradually progressive. Initially, it was dull aching, mild in intensity, intermittent in nature, localized to the back of the head and upper neck, non-reading in nature. She took frequent neck massage and occasionally over-the-counter medication for pains. Later, she noticed occasional radiation of pain to the area just behind the right ear, especially while flexing the neck and also while coughing. There's no history of any aggravating and relieving factor. There's no history of any diurnal variation of pain. There's no history of restriction of neck movement. There's no history of neck trauma and neck trauma. There's no history of prolonged use of screen, television, and abnormal neck posture. There's no history of fever, weight loss, and loss of appetite. There's no history of morning neck stiffness. There's no history of back pain. No history of worsening of pain on the neck movement except flexion. There's no history of neck tilt. There's no history of headache, seizure, and altered sensorium. Second complaint is burning sensation. We also mentioned about the burning sensation all over the body. It was insidious in onset Initially, it is started in the left upper limb, gradually progressed to the involved left half of the trunk, left lower limb, and then right side of the body. Initially, it was intermittent in nature, but later it became continuous. There is history of cotton wool sensation while walking. There is no history of band-like sensation. There is history of partial relief of symptoms after medication. There are no aggravating or relieving factor. There is no postural and diurnal variation. She also complained of decreased feeling of hot and cold sensation since 9 months. It was insidious in onset and gradually progressive. She could not feel the touch of hot and cold water, because of which she developed multiple burns over the left hand and forearm. History of slippage of chappal without knowledge. There is history of decreased feeling of cloth over the either half of the body. There is history of decreased perception of pillow below the head. She also noticed tightness of the right hand while doing kitchen work. She gives history of sudden tightening of muscle and not being able to leave the object, like unable to let go the frying pan. Pulling sensation of the thigh. There is history of involuntary movement of leg while sleeping. She also complained of weakness in the right of the body, which was insidious in onset and gradually progressive to involve the right lower limb after about 2 months, followed by the left upper limb and left lower limb within about 1 month. There is history of these are the history in the following chronological order. Difficulty in writing. There is change in handwriting with increased letter size, which was then followed by the difficulty in holding pen, difficulty in buttoning and unbuttoning of blouse, difficulty in breaking chapatis, difficulty in eating with the right hand, and thus she started using left hand for the same. Difficulty in holding glass mobile with the right hand, difficulty in combing hair with the right hand,
Okay, Paras.
and started.
Okay, Paras.
Yes,
I
sir.
just interrupt you. This Shivkaran, what are the symptoms? All the symptoms which is written in this slide make you understand what is happening with the patient. All these kind of difficulty in writing with right hand, buttoning, unbuttoning, breaking chapati, sitting in right hand. All these kind of things. What do you understand by what is happening with the patient?
So the patient is having weakness, more of the distal weakness to
Very
proximal.
good.
Then
Distal
the
weakness, yes. Then in the fine
motor movements.
movements.
That is
This is affecting the fine movements of the
movement.
hand, right hand specifically, what is mentioning here.
And
So what do you understand? What is happening? Which substrate is involved in these kind of symptoms?
so in the fine movements of proprioception, the spinal.
Proprioception nahi hai. Proprioception is altogether different.
So
This is the
cortical
weakness.
spinal tracts.
Sorry?
Or-
Corticospinal tracts.
Tracts.
Yes, I wanted to listen. This is a corticospinal characteristic in case of cervical spondylitic myelopathy में आपने देखा होगा ना?
Yes,
बहुत
sir.
सारे elderly patients, 70 years, 65 years, farmers, laborers, they have these kind of characteristic symptoms. Go to the first symptom you go, Paras, and let us discuss with Dr. Gill what is happening with this patient in the first kind of neck pain. So what kind of neck pain is this?
So it is a radicular pain, sir, as he has mentioned that it is localized to the back of the head and upper neck, and that is the non-radiating. But then
why do you use the word radiculopathy?
so then she noticed occasional radiation of the pain to the area just behind the right ear, post-auricular pain.
So which radical goes there? Which root is causing pain there? This is a diffuse kind of pain.
Yes, sir. C2, C3 nerve roots, sir.
Maybe, yeah, but it is not radiculopathy, na characteristic. It is like he has written non-radiating. He has characteristically non-radiating. So whatever information is there with you, it is non-radiating. It is not radiculopathy. It is diffuse. And then go to the next symptom. Burning sensation all over body. What do you understand by this symptom? Or what make you to understand which substrate is involved?
So burning over this is the related to the spinothalamic, and that is because of the dissociative sensory loss. That is, it has in the weakness, burning sensation all over the body, which was insidious in the left upper limb, gradually progressed to the left half of the trunk.
So it's a left upper limb gradually progress to involve the left half of the trunk and left. So left-sided burning sensation sort of.
Sensations.
So where is the localization? Where is the substrate involved? What substrate leads to this symptom?
So spinothalamic tract.
Spinothalamic. So there is neck pain with the spinothalamic on the left side involvement. Next symptom.
Sir, actually the burning sensation is all over the body, sir.
It is all over the body.
Yes, sir. Initially it involved the left side, then it involved the right side of the body.
Now it is yes, it is like it started with a unilateral symptom, which is obviously any sort of unilateral will have expansion of that lesion wherever it is, and finally all kind of symptoms. Next. There is decreased feeling of hot and cold sensation. So temperature is lost. Where? You have to do that shift.
That is, yes, sir. Decreased feeling of the hot and cold since 9 months. That was the insidious and gradually progressive. So spinothalamic tracts involved in this also.
Again,
And,
spinothalamic.
and he couldn't feel the touch of hot and cold and the multiple burns over the left hand and forearm, sir.
So there is history of slippage of chappal also without knowledge.
Without
But
the knowledge, sir.
so this is spinothalamic.
And the so
Or posterior column
posterior column also, sir.
is also involved in this symptom. During like explanation of the symptom, he has included posterior column also. Okay, next. Again, stiffness, corticospinal.
Yes, sir. Spastic.
And fifth also goes into this finally. Next, Paras.
Yes, sir.
And
Further.
the gradually quadriparesis, sir.
Next. You can start reading.
There is difficulty in negotiating right foot into the footwear. There is of dragging of the right foot while walking. There is difficulty in walking first, even on even uneven surface, then on even surface. But she was able to walk around. But with progression of weakness, she needed to steady herself with a walking stick. But now needs assistance of another person to even sit and stand. There is difficulty in getting up from squatting position, difficulty in getting down from stairs, then upstairs, difficulty in holding mobile and glass with the left hand now. And now she needs assistance for the same. Difficulty negotiating left foot in the slipper, difficulty in raising head from the bed in last 20 days. There is difficulty in sitting and getting up from the lying down position. History of difficulty in turning sideways in the bed. History of raising arm above shoulder and turning neck to the left.
Okay, next.
Negative history. Sorry, sir.
Yeah, continue.
No, there's no history of decreased perception of smell. There is no history of diminution of vision, decreased perception of color, difficulty in seeing sideways. There's no history of double vision, abnormal deviation of eyeball, drooping of eyelid, difficulty in looking downward and sideways. There's no history of loss of sensation over the face, difficulty in chewing, and there's no history of current-like sensation in the face. There's no history of painless ulcer in the mouth, no history of drooling and saliva from angle of mouth, no history of deviation of face, no history of difficulty in closing eyes. There's no history of reduced hearing, tinnitus, vertigo. There's no history of nasal regurgitation, hoarseness of voice, difficulty in swallowing. There's no history of difficulty in articulation of speech. There's no history of difficulty in breathing.
So most important,
There's no history
negative history क्या है इसमें, Dr. Shivkaran?
So the most history is the weakness that first is
most important negative history in this slide.
Sir, the cranial nerve involvement, sir.
Yes, there is no cranial nerve involvement. Lower cranial nerve involvement is ruled out by this overall history given by Paras. Next.
There is no history of excessive dryness of either side of face, no history of blurring of vision, no history of drooping of eyelid. There is no history of urinary frequency.
Yes, let me interrupt in the interest of time. There is no history of autonomic symptoms also.
Yes, sir. Yes, sir.
Next, go to the next.
Past history, my patient is known case of rheumatoid arthritis and on medication since 9 years. There is no other significant past history. Family history is also not significant. Personal history consumes mixed diet, appetite normal, sleep is undisturbed, bowel and bladder habitus is regular. There is no history of addiction. Menstrual history, attained menopause at age of 45 years. Earlier menstrual cycle were normal. Obstetric history, P3, L3, married at the age of 18 years. I would like to summarize now my patient, Mr. Rita, a 56-year-old female, right-handed, resident of Riva district, presented with the chronic neck pain in the occipital cervical region, occasionally radiating to the right retroauricular region on the flexion of neck and cuffing. And there is insidious onset chronic burning sensation all over the body, except face and neck area. There is decreased temperature perception in the right half of the body and back of the head, except face. Progressive stiffness of all four limbs, progressive weakness of all four limbs, including weakness of neck flexion. Since the last 3 months, the patient has been bedridden and dependent on others for day-to-day activity and is currently wheelchair bound. There is no issue of bladder and bowel involvement.
Okay, Dr. Shiv. George, sir,
yeah. One quick question. Paras, see, in your progressive stiffness of all four limbs, progressive weakness, you have to, really put forward what is the temporal profile, which started first and how it progressed. That is a significant bearing on your localization. So to go further, how do you actually on your history and examination differentiate between intradural, extramedullary, extradural and intramedullary lesions? Quick one point. Okay, it is in fact the temporal profile of progression of weakness is used to understand that. Which limb started first? Yeah, which limb started first and how did it progress? Quickly, and use that to explain this localization.
In the intramedullary, the early sphincter involvement will be there. In the extramedullary, there will be the late involvement, and the pain will be in the intramedullary will be the funicular, and in that will be the root pain.
What is suspended and dissociated sensory loss?
So in this, as he complain of the right upper limb, first the right upper limb, then the contralateral lower limb, and then the corresponding upper limb and the lower limb.
No, that is not the perfect answer. Paras wants to try.
Sir, in case of suspended sensory loss, there will be involvement of spinothalamic tract while the sparing of the dorsal column.
So why do you think it is, what is a feature of a intramedullary lesion?
Sir, because intramedullary feature will expand from the center to periphery, so the spinothalamic tract will come first. It will get affected first, and at the end of the disease or disease progression, dorsal column will get involved.
So in each of these long tracks, can you tell us how is the temporal or the profile of distribution of cervical, thoracic, lumbar and
Sir,
sacral?
in spinothalamic tract, sir, the order is cervical, thoracic,
Medial
lumbar, and
From the
Sorry,
medial,
sir?
from the medial to
medial to
Medial to
lateral,
out.
to medial.
Medial to lateral, sir.
Okay.
Cervical, thoracic, sacral, and lower limb, sir.
and
In the
column, the sacral.
motor,
In the corticospinal tract, what is most lateral?
So
most
sacral.
Okay.
Final is the cervical, sir, more lateral.
Right. Okay. So one quick point on differentiating extradural from intradural extramedullary.
The symmetrical and the non-symmetrical. In the extradural, there will be the symmetrical involvement with the vertebral pain, sir.
Okay. Intradural extramedullary.
In the intradural extramedullary, there will be the early involvement of the intramedullary. Early involvement of the sphincter, sir.
No.
Roots. There will be roots, na intramedullary, extramedullary, intradural. There will be roots. Radiculopathy will be first symptom.
And the asymmetric or brown checkered like presentation also is more common in intradural extramedullary. Okay, in among all these tracks, if there is a ischemia of the spinal cord which is most vulnerable, in other words, what are the watershed zones of the? So if there is a hypotension during your surgery, which tract is likely to be most affected?
sorry, sir.
Okay, so that is something we don't have time to discuss. We have horizontal and vertical watershed zones of the spinal cord. So when you present this in your exam, as soon as you come to the diagnosis, you should have a cross section of the spinal cord at your localization level drawn, so that the examiner also knows that you know it well and you don't have to struggle hard to explain your answer. So this cross section should have all your especially your long tracks and this temporal profile of distribution of lumbar, sacral, thoracic and cervical. Okay, and then you don't have to struggle hard to explain your answer. So with your final diagnosis on the last page, there should be a nice cross section of the spinal cord drawn, preferably also with the blood supply of the posterior spinal arteries and the anterior spinal artery. Okay. Okay. So what?
Paras, what you have written? Yeah. What are the differentials you have given for this patient? And does Dr. Shiv agrees with it?
So these are my substrate analysis, sir.
Dr. Gill, do you agree with the burning sensation of all over body, bilateral posterior column?
Yes, sir.
You agree with this? What are the?
So in your substrate analysis, see, though you have said bilateral posterior column, you have to always, again you have said that bilateral corticospinal, but that temporal profile of which started first, was it lower limb first then upper limb, that has to come in this substrate analysis slide. What is the direction or the profile of progression of the corticospinal tract involvement? Was it initially symmetrical then became symmetrical? and what started first. That is very important in your localization.
Okay, sir.
Dr. Paras, what are the sensory modalities transmitted through the posterior column?
Proprioception, vibration, and joint position, sir,
Fine touch also.
and fine touch also.
So burning sensation all over the body is a symptom of bilateral posterior column involvement.
That
I
is
think
the spinothalamic.
it was already told by Dr. Shiv in the initial presentation slide, second or third one, I guess. So this is you have to correct it, and then reduce temperature. So what do you think, Dr. Shiv, that where the pathology is? Finally come to the
So as there is
localization.
no cranial nerve involvement, so it will be the below up the fine motor above C5 and below
Foramen magnum, you want to say, because there are no cranial nerve involvement. Very good.
myelopathy signs are there.
Yes. So it is an intradural, intradural or extradural pathology. Come
So
to the next slide. Next slide by the time. Let us see what you have written. Go further. Okay.
intradural extramedullary.
Intradural extramedullary. Why?
So as the first is
Because as George was mentioning, the temporal association of all the symptoms. How does it started? Unilateral. Unilateral is more common in case of extradural.
extradural.
Neck pain is extradural or intradural?
And the progression is also distal to proximal, sir.
Yes, and then
Bladder.
yes, very good. And then neck pain, is it
There is no-
intradural or extradural? Neck pain, especially in a patient who is known for RA.
So extradural.
Extradural. So, and then above, obviously above C5, below foramen magnum, can be clinical tests on physical examination which can differentiate Shimozi's reflex and all those things, but still will go above C5, below foramen magnum. There is no 11th and 12th or lower cranial nerve involvement.
Cranial nerve
No
involvement.
other facial and all those things. So come to the
As
next
there is
slide.
no bowel bladder involvement is also there. So
No bladder bowel involvement. So extradural. Extramedullary at least. Okay, next. Go to the next slide.
General examination, belt is average, moderately nourished, pulse is 80 beats per
Only
minute.
positive finding you can
regular-
mention in the interest of time, Paras. You can mention only the positive finding in neurological examination, especially
Okay.
corticospinal tract and sensory. Go to those parts. Yes, there is nothing significant, and then go further, go further.
Sir, there is in the oculometric examination, there is a downbeat nystagmus is seen, sir.
Yeah, downward nystagmus localizes to what area?
Sir, cervicomedullary junction, sir.
Foramen magnum, maybe. Yeah. Okay.
Yeah.
Then come to the next slide. Nothing positive. Okay, normal. Next, normal.
Yes, sir.
Next. Spinal
So there is
accessory.
there is involvement of sternocleidomastoid and trapezius, sir.
On physical examination, and it correlates well with the history in which you told there is a difficulty, recent history of elevation of the head or flexion of the head out of this, like.
Yes, sir.
Next. Okay, so there is involvement of right side sternocleidomastoid, right?
the
SCM.
right side.
And then
Sternocleidomastoid and trapezius.
so there is right 11th nerve involvement. You want to say?
Yes, sir.
Okay, next, go ahead. No 12th nerve involvement. Next.
Yes, sir.
What is this? Mass modified Ashworth.
Modified. Yes, sir.
Okay. Grade 2. Bilateral. Next.
Asymmetrical.
Right side had a more.
Right more than left, and there was left more than
Yes,
right
sir.
on the sensory examination, especially the to start with at least. Yes or no?
Yes, sir.
What is Brown sequard?
Brown sequard in Brown sequard syndrome, there will be the ipsilateral weakness, and there will be the ipsilateral posterior column signal,
And contralateral.
posterior column and contralateral spinal.
This
Contralateral
was
spinal.
happening. This was happening in your case.
No.
No, sir.
Why? There was left side or right side. Which one?
The right side upper limb, right side lower limb, and then the left side involvement.
No, I am asking pain and temperature. Where was this involved? Left or right?
Sir, right.
Right side, sir.
Just on
Again, the
right
same side. So both are on the same side.
Yes.
Okay, so there is no brown. Okay, next. Palpation pe power, I mean, is it atrophy you could have mentioned or bulk? You can always start with
Okay,
the
sir.
bulk. Well, inspection.
Okay.
What was the bulk?
I,
Okay, anyway.
that I mentioned in earlier, sir. Actually.
What was it? You no need to
It was
go back.
normal, grossly normal, sir,
Normal,
but
okay.
there is worsening of thenar and hypothenar means.
Okay, okay. Come to that slide which you just left. Further. Go further. Okay. So there is extensor and Hoffman present bilateral. Next.
Yes, sir.
There is graded sensory loss on pain, temperature, touch, all below the level of C4
Yes.
and C2 for touch, root touch.
Yes, sir.
Okay, go further. Dr. Shiv, you have to keep all these things in mind and you have to localize the lesion. So JPS is also impaired, huh?
Yes, sir.
Upper limb, lower limb, both.
Both.
Romberg unable to perform. Next, she is wheelchair bound, I guess. Okay.
Yes, sir. Wheelchair bound.
Cerebellar, not possible. Next. When it's wheelchair bound, cerebellar is not possible. Systemic is
Yes,
leave
sir.
it. Okay, now tell Dr. Shiv where is the localization after physical examination?
So it's above C5 and below foramen magnum. The more
That is
is
vertical,
down
okay.
vertical.
But now there is involvement of 11th also.
11. So, but that can be this now the lesion has been above C3, C4, sir.
Why?
As the sir trapezius and the sternocleidomastoids are being supplied
Are
by
also well supplied. Okay.
that is-
Okay. Next.
so now the cutoff has been to the below foramen magnum or at the
At the
above
foramen
C3. Yes, sir.
Okay.
And
What pathology can be there? Okay. Vertical localization you have done well. And horizontal or axial localization. Is it intradural or extradural? Or intradural, then is it extramedullary or intramedullary? Final thing from your side and then pathology.
so it is the extramedullary pathology.
Extramedullary. Why do you say? Because there is neck pain, number one, and then asymmetrical. But
Symmetrical
there is
involvement. And the third is the
no
Bladder
bladder
bubble.
bowel.
no blood bubble
So
involvement.
you'll go for extra dural above C3 or C4
Before
and below foramen magnum or at the maximum at foramen magnum.
foramen magnum because of the downbeat
What,
nystagmus.
what pathology can be there?
So
Extradural.
for so any bony lesion that is compressing or the that is extending towards the foramen magnum or the foramen magnum meningioma, sir.
Foramen magnum meningioma. So meningioma is the intradural or extradural?
So intradural.
Intradural, but you just mentioned extradural pathology you are localizing.
So
Paras, you agree?
intradural, sir.
Can it be AAD?
So that is because of the history of the rheumatoid arthritis. It can be associated with the
And neck pain was
axial
worsening on neck movement. Huh? There was flexion and then
that is involvement of the C2. That is as the patient is having
but
pain.
side to side, more importantly, side to side movement is more important in AD, which is negative here. You have to keep
Yes.
all this in mind. Paras, do you agree with AD or disagree?
Disagree, sir. There is no restriction of movement, sir. There is only
Side to
flexion.
side, especially side to side.
Side to side, yes, sir.
Then
Then there is no
so
CVJ
do you
marker is
agree?
not
Do you
seen.
agree with the meningioma or intradural pathology just mentioned by Dr. Shiv?
Yes, sir. Intradural extramedullary pathology, sir.
Okay. Why it is not intramedullary pathology? Why it is not a cervical ependymoma? There is no radiculopathy. There is no, and there is a cuff headache also. In which pathology do you get cuff headaches?
Raised ICP and PIVD and
You can tell a number of things. Chiari malformation, man, in CV
Chiari
junction
malformation.
mitosis.
Yes.
So
Yes, sir.
Chiari with
Chiari.
syringe have a typical cuff headache. Okay, especially
Yes,
the
sir.
localization of your posterior fossa C2 and retroauricular you mentioned. Typical of Chiari with syringe. So why it is not a cervical intramedullary astrocytoma or ependymoma? Ependymoma in case of what is the duration of the history? How many?
So 11 months. 11 months, sir.
11 months. So why it is not a cervical astrocytoma, ependymoma, or syringe with Chiari? And fourth, maybe a AD.
So
I would still keep it.
upper
Sorry?
motor neurons signs are not there.
Upper motor, UMN kind of, it is there, nice spasticity is there, fine motor movements of the hands are there, corticospinal tract. What else UMN you want?
So, but on the examination, he has mentioned the reflexes are.
No, there were exaggerated Hoffman present, bilateral Babinski, like extensor plantar. It was there, na Paras?
Yes, sir. There, sir.
So we have discussed all based on the history. See, the idea is to discuss all these things. So Dr. Shiv, tell me where is the final pathology you want to keep before you get a, I won't accept meningioma. It is an intradural, slowly growing, posterior column should be first, dorsally origin, female. This patient is a female, na, Paras?
Yes, sir. Female.
Yes, sir.
So
Female,
that I
female.
agree. Okay, but not middle age. So I agree with this. So this is all is, tell me now. I have told you all the positive negatives. Now at least you localize you.
The foramen magnum.
Still you want to go for foramen magnum. Why can't there be a cervical? You
Mild.
can, as George Sirs were mentioning, you have to see the temporal association. Where the symptom first started. Neck pain is number one. Followed by there was
Distal to proximal.
distal to proximal, and then there was a burning sensation loss or burning sensation, especially on the left side, and then followed by whole body. Followed by there was weakness. Yes or no?
Yes, sir.
So ये
Yes, sir.
क्यों इंट्रामेडलरी सिरिंज नहीं हो सकता with cough headache?
But the
Yes or no?
But because, sir, weakness pattern is distal to proximal, there is no bladder wall involvement.
Yes, so you have to come up with this. There is no bladder bowel, no autonomic symptoms since the beginning, and still it is not there, I guess.
no,
Yes,
sir.
sir, it is not there, sir.
No.
Yeah, but I doubt if I take the history, there must be some urinary bladder symptom will come. But
No,
you
it
have
is not there, sir. It is not at all. Patient is self-voiding.
then I agree with your confidence. Okay, agree. Then you go ahead. So final you tell. Final diagnosis, Dr. Shiv, and we'll move to the OSCE section.
So foramen magnum, intradural, extramedullary, sir.
You're stuck to the foramen magnum, I don't know. George, sir, final conclusion, and then we'll go to the
Yeah, fine. Jitendra, only one more point is that, see, you could also have a coexisting extradural and intramedullary. Like, for example, you could have a CV junction
Dumbbell.
anomaly like
Sonoma.
no, that is also a possibility. What I meant is that you could have a CV junction bony anomaly like AAD due to this rheumatoid arthritis, and sometimes bony CV junction anomalies are associated with intramedullary syrinx. So that
Syrinx,
also is a possibility which we have to consider. Not
yeah.
only not only in Chiari, you could also have in bony CV junction anomalies. You could have a syrinx, and
Then
also we have to keep in mind. So the important thing at the end of your history and examination is that to be unbiased and think laterally, think of all possibilities, and as much as possible don't get into a template or a mode. Just because you keep on presenting some cases, you get into a mode and template. Sometimes every patient is unique and every history has got a lot of beautiful aspects which you have to pick up and think laterally and make your own creative diagnosis where all the points fit in.
yes, sir.
Okay, go ahead.
Yeah. Evaluation and just tell what you will do. This is summary. Okay, Paras, next slide. Next slide, finish it fast. Foramen magnum meningioma you have put first. What made you do like which headache and then burning sensation? Okay, we have discussed all this. We'll just move on next. I would still go for intramedullary pathologies first. Okay. See, absence of symptoms of bladder or autonomic doesn't rule out.
But, sir, pattern of weakness is also distal to proximal. And there is
Okay.
no dissociated sensory loss also is not there, sir.
Dissociated is not there.
Sensory loss is there.
Not there, sir, not there. Both column were involved, sir.
Okay, fine then.
Yes, sir.
Okay, so you localize to CV junction or cervicomedullary junction. C2 is the highest, and DTR's horizontal is intradural, extramedullary. You have labeled it to foramen magnum meningioma because imaging is going to show that. Okay, go ahead. Go ahead. Next, finish it. Shiv, just read the scan.
Considering the points that Jitendra sir told in the previous scan. Read it properly, please.
So the hypointense lesion is present at the cervicomedullary junction.
Hypotension on T1. If
T1.
T1 axial is not there, you ask. Paras, do you have T1 axial?
On T2, that is.
It's
No, sir, I
1830.
don't have.
Whatever you have, these are the images only. These are the only images you have, Paras.
Yes, sir.
So
Okay, T2 axial you read. Shiv, you can read T2 axial.
So hypointense lesion is present at in the T2 at the cervicomedullary junction with the
With the
I think
cervicomedullary
that is the
junction.
kinking, causing the kinking at the of the cervicomedullary junction and the upward push of the cerebellum, and the CSF flow is not seen. The
So there is
compression
CSF cleft
at the
in his-
medullar level.
Okay. And there is distortion or
Broad-
displacement of some major vessel is there. Maybe in contrast, you could appreciate. Okay, T2 Sag you read. Read T2 Sag.
Yes, sir. So the broad-based lesion is present at the
Very good. And there is a T2 hypointensities also.
hypointense.
You can see at the junction where the origin is from the lower end of the clivus. Yes or
Yes.
no?
Yes,
And
sir.
then it is the tumor is expanding posteriorly, displacing the
Generally, it is the
cervicomedullary junction, obliterating the CSF spaces not seen across the foramen magnum. Very good. So T2 hypointensity, what does it indicate to you? What do you make out of it? If a lesion is T2 hypo, what does it indicate? Is it soft or is it firm? Is it hard, cystic? What does it indicate?
I need the differentiated images also to and the
Chalo, anyway, no problem. Okay.
More of solid components, sir.
Generally,
It is high.
they become firm. Yeah, solid only. But see, remember, Dr. Shiv, whenever T2 hypo, especially you are suspecting meningioma or these fibrous tumors, dural based origins, you should vestibular schwannomas also. You can generally there will be firm. Yes or no? Okay. Chalo. Contrast. Paras, where is contrast? Is it there?
Yes, sir.
Yeah, it is there. Yeah. So it is
contrast, it is enhancing, sir, and the broad-based tail.
enhancing brilliantly and uniformly. There is no areas of necrosis also. Learn all this for your final exam. Okay. And there is a severe compression over the brainstem. Okay, fine. And whether there is carry or not, you have to see in T1 or T2 sagittal, where was there any carry formation like?
No, sir. No, sir.
Sorry, this one. Sorry,
It is not there.
Syringes.
Not there.
Yes, sir.
No, sir. It is not. It was not there, sir.
Perfect. Chalo. So I think operative will leave.
We can ask a little bit. Yeah. What
approach will you
time,
take?
sir. You can ask.
What approach will you take, Dr. Shiv?
So far lateral approach, depending upon the position of the lesion that is related to the vertebral artery or the.
The case
how do
is
you
in front
classify?
of you, Shiv. You could just tell right, far, lateral. What
right.
kind of? Yeah.
Okay.
So right far lateral approach will be considered.
Perfect.
And the lesion is anterolateral, sir.
How does far lateral differ from RMSOC, the standard RMSOC?
So the hockey stick incision is
one then.
And so then we have to go separate the vertebral artery, sir.
From?
And the from the C.
Some important structure has to be violated here. Some bony.
So C1 laminectomy and the.
Dialer drilling needs of fund.
So,
Paras, you're not Shiv, man. Don't answer unnecessarily.
Okay.
Occipital.
Dr. Gill, yeah, go ahead.
Drilling.
What will you do in a far lateral? How do you position it? Is it positioned differently? What extra are you doing?
So condylar drilling by.
Don't read the answers, man. They're trying to dissuade you. Don't read the answers.
No, that is not the answer I was looking for. Something about foramen magnum.
So you have to tell the basic at least. You cannot. You have to tell ki how will you kind of do the craniotomy at least. I don't expect you to tell the whole thing, but something has to be told. One important thing which I would like to have you mentioned is which vertebral artery is the dominant one here. Could have been thought. That decides most of the situation.
So right side.
How will you counsel this patient?
So by telling them the weakness associated with the surgery, then the low cranial nerve involvement will be there. If the patient can go on the long-term ventilatory support, sir.
Yes, weakness तो already है ना उसको.
Yeah.
Already 3 wheelchair bound है or bed bound posterior. Anyway.
Very important to tell about lower cranials basically. That is what has
lower cranial. Need for tracheostomy and prolonged ventilation as you mentioned.
Exactly. That is the thing.
Chalo.
Okay. We'll go move to Oskis. Prashant, you want to go first?
Yes, I'll share my screen.
Nicely done, both of you.
Prashant's questions are directed towards Dr. Paras.
So, Harsh, can you see my screen?
No,
Not yet.
I'll try again. Wait.
Should I start by the time?
Just 6 seconds.
Yeah.
Yeah. Mhm. Try sharing your screen, right?
Yeah, I'll do that. So these questions are directed to Dr. Gill. Okay. So 28-year-old female with headache and right hemiparesis. Kindly see the scans. When you're ready, I'll display the questions. Jitendra sir and Dr. George, you can ask anything apart from these questions also. Our questions are just like kind of indicative. You can go. You can ask extra questions regarding these cases. Dr. Gill, is it okay? Should I start displaying the
Yes.
questions? Yeah.
Yes, sir.
So, what is the most likely diagnosis in this case? Just one.
So left thalamic, sir.
Left thalamic glioblastoma, left thalamic
Left thalamic
pilocytic.
glioblastoma, sir.
Okay. Paras, would you want to change the answer to whatever she has said? Do you want to change it or you want to keep the same answer?
So there is complete restriction of the diffusion weighted.
Yeah.
Like
So what will it be?
abscess or
Exactly. So
tuberculoma.
this is a pyogenic abscess. Okay. Not tuberculoma. Do not. Why is it not a tuberculoma?
So there will be heterogeneous component will be in the T2 weighted.
Sure. Okay. So what are the risk factors for this condition, Dr. Gill?
So there will be the memory disturbances, the
Pyogenic abscess, the first answer is memory disturbances.
Not the symptoms, risk factors. Dr. Shiv, just read the question again.
mention the risk factor for this condition.
Abscess case. Dr. Shiv, this is like absolute basic.
If there is infection, what are the risk factors? This is an infection, na, in CNS.
The immunocompromised patient in any of the then the tuberculum.
No, man. You were getting on the right track. Immunocompromised. What kind of immunocompromised?
So tuberculosis.
Tuberculosis is the effect of immunocompromisation, right? What is the cause of immunocompromised? If you are unable to, you can just say you don't want to
I
answer.
will.
Yeah, Dr. Paras, do you want to take this question?
So the risk of rupture, that patient will go into the meningitis.
No,
septic
man.
shock.
Risk factors for this condition. Causative factors. Let me. Yeah, cause of abscess.
So respiratory and cardiac.
क्या हो रहा है आज? 28-year-old female, man.
देखो इसका सर्जरी तो हुआ नहीं है कि बाहर से आ गया इन्फेक्शन.
Exactly, yeah.
कहाँ से आया इन्फेक्शन ये?
It's very typical.
कार्डियक कोई तो लेकर आ
चलो,
रहा है.
I'll say it is a 2-year-old. It is a 2-year-old. Now answer the question.
Endocarditis.
Okay, then 2-year-old, what are the factors? Come on, you have to answer. This is like.
Sorry, sir, I don't.
Okay.
Cardiac
Enumerate
imaging.
what are the imaging features to differentiate pyogenic abscess and cystic glioblastoma, Dr. Gill?
So in the pyogenic, so in the cystic glioblastoma, there is a full enhancement on the T1 ring enhancing lesion will be there in the both.
It is there in this, yeah. Then
on the DW weighted image or the SAWI, there will be the necrosis or the cystic areas will be there.
No, it's not okay. Dr. Paras, anything else? See, the next question is actually the answer to the question that I'm asking.
The edema, the amount of edema is.
Yeah. That's a good
Okay.
answer. Yeah, good. Something you're telling me. Come on, edema is more in abscess, more in glioblastoma.
More in the glioblastoma.
More in abscess.
More in abscess. And what else?
And there is a complete diffusion restriction in the no solid component.
And what is this dural ring sign that we are talking about? What will happen to the restriction? Why
There will
does
be
abscess restrict and glioblastoma does not restrict, or restricts only to a certain degree, restricts only at the rim?
So in the
because of
center,
necrosis, sir, hypertelos.
in the pyogenic abscess, there will be the diffusion restriction in the center is there.
And in the glioblastoma,
So in the periphery,
what is this dural rim sign as it is called? When does the dural ring sign happen? This is one of the
on the
like the
T2,
major emergencies that you will always face in your career. I mean, if you cannot differentiate, this is very, very surprising. I thought this everybody would be able to answer. What is
So there will be
the thing that you're worried about in
capsule.
this case?
Worried about this
the
case.
ventriculitis and the
Yes. I guess.
Yeah. So what will you do? What is the plan in this case? If this case comes to you at around maybe evening time in your emergency, what will you do?
so we will do the we start with those higher antibiotics, or we will plan for the EVD.
Oh God, EVD.
Mhm.
Probably the
Sorry.
last thing that I
Yes, sir.
would do. What will you do,
Neuro
Dr. Paras?
navigation.
Yeah. You were saying something.
Neuro
Yes.
navigation guided burrow and tapping, sir.
Yeah. Navigation
Okay.
or not navigation, but Barholt and tapping
Ah,
should be done of the
tapping.
abscess immediately.
And we will start with the higher antibiotics for 4 to 6 weeks at least.
You will do before the tap, after the tap.
So
After the tap, sir.
So we will start the antibiotics, but after the tap, the culture will be sent, whichever antibiotic will be
Mhm.
according to the
If you
culture.
can do the tap, you do the tap first and then start the antibiotics. What else will you send in this case?
Other than culture sensitivity, sir.
Yeah. What else? Apart from the pus culture sensitivity of the abscess, what else will you send? What infected
Cytology
panel
for
will you send?
cytology, sir.
Cytology of what?
Cytology तो आ जाएगा ना culture तो.
That all is fine.
Nocardia,
Will you send for blood culture or not?
so nocardia, blood culture.
So these are the things that you have to answer, right? As soon as the patient comes, I will get a CBC, DLC, blood culture, and look for IV drug abuser signs, send retro, check for diabetes, alcohol. There are so many things. I mean, this answer should be like you should just start speaking and not stop for till okay. Chalo, theek hai, I'll go ahead. I don't know.
This question number 2 was same only, है ना? IV drug abusers,
Yeah.
HIV. These were the
Exactly.
factors.
Yes, sir.
Congenital heart disease. Dr. Shiva, read about
Yeah,
it.
sorry.
Paras.
Okay,
Sorry.
Dr. Shiv,
Sorry.
this is your second. See the images. Please read upon abscess. It is non-excusable in this day and age in this country to not answer this question.
Yes.
Okay, wherever you want me to stop, Dr. Shiv, you can
Just
tell
stop.
me. Okay, this is the other image that you would have wanted.
So stop.
Yeah, okay. Okay, he's a 70-year-old male with neuric grade 5 myelopathy. What is your diagnosis in this case?
So it's a ossified posterior longitudinal ligament, sir,
Of the lumbar vertebra, of
of the
sacrum,
cervical vertebra, sir.
of which level?
At the so kindly show me the
So
picture.
this was the thing, no? You should have said this beforehand only. You should have, these things have to be seen beforehand.
Sorry, sir. So at the level C5, C6, sir.
Only?
And it is extending from the C4 to C6, sir.
Okay, fine. So what is the plan for this case?
So
This is a, suppose that this is a standing CT. If you, very rarely it is done, but suppose it is a standing CT. What is your plan for this case?
So first we will calculate the K line.
What
So
is the K line?
so it is Full canal. So I'm unable to explain.
Paras, acha, these questions are for Dr. Shiv.
Yeah, if you are unable to answer, it will go to Dr. Paras, yes, obviously.
So which
Okay,
factor?
if you can answer the third question, you can answer the second question also. What are the factors deciding anterior versus posterior in this case?
So if more than the three levels are involved,
Hmm.
then we will go for the posterior.
And that is
And
one. Very good.
K-line,
Then,
K-line is more than the.
okay, let us suppose that you don't know about K-line. What are you trying to look with K-line actually?
So whether to we will go for the interior approach or the.
What is K-line
By seeing
testing
what?
for? What is K-line testing for?
So I couldn't.
What is kyphosis, lordosis?
So there is a loss of the lordosis in the cervical.
Okay.
The osteophytes are also seen.
Okay. So how does that change your answer? Like if there is a loss of lordosis and there is, which means there is kyphosis, would you want to go anterior or posterior?
Yes, sir. That depends on our approach, key whether we want to go for the posterior or if the
Yeah, that is what I'm asking. In this
if the
case,
K
there
line is
is
positive, we will go for the posterior approach, laminectomy, and the later mass fixation.
okay. And in this case,
So in this case, we will go for the posterior approach, later mass fixation.
and does lateral mass fixation change the outcome in this case? He's a 70-year-old male, as I told you.
So either we should also go for the 360 rotation, sir.
360 what?
360 degrees, sir. Anterior and posterior. First we go for the posterior and then
You want to do a laminectomy and a corpectomy
no,
in
sir.
this case. Then I didn't get you by your 360 thing. What are you trying to imply regarding 360?
Sorry, sir.
Dr.
think
Paras,
what
you want? Yeah. Pune, please. Sorry.
I think what Harsh wants to ask is, can you do away only with laminectomy in this case, or you really have to put lateral mass screws also? At this age, seeing the bony pattern, the formation of osteophytes is.
we can only go for the laminectomy.
Okay, Dr. Paras, has lateral mass fixation shown to be of benefit in OPLL in any which way? Is there some theoretical advantage to it?
Is preferred, sir. So I would like to go in the C5, C6 corpectomy with the under drilling of the C4, sir.
In a 70-year-old male?
Or other thing, 70-year-old we can do the lamina.
What is the problem with doing C5, C6 corpectomy in this case? What do you think will happen?
So the patient will go on the long term. So there will, as it is a ossified posterior longitudinal ligament, it will be adherent to the dura.
Yeah. So CSF leak can happen. Yes, very good. So what is the advantage of doing lateral mass fixation or any kind of fixation? There is a theory regarding this, right? What is the advantage to this? Why does OPLL form in this case for the first thing?
So degenerative changes in the because
Why does degenerative changes happen? Paras, anything?
Loss of lordosis. Sir.
You're just answering the same thing, just saying the same thing what I am saying. So what is the theory is that there is a micro movement which happens, which causes this OPLL formation. So lateral mass fixation will lead to stoppage of this micro movement. And there is a theoretical advantage that people say that the OPLL will reduce, but it has not been proven as such. Okay, Prashant, you can go ahead.
Yes. Can you see my screen?
No, Prashant.
Abhi?
Yeah, I think so. Yes.
Something. Yeah.
Yes.
Exactly. So
Yeah, we can see it.
yeah, so this is a 2-year-old female child. Paras, are you listening? Who
Yes, sir.
presented with weakness of the left upper and lower limbs for the past few days with no other significant complaints. Now, can you describe the MRI findings and localize the lesion?
This is in the axial weighted axial MRI, sir. There is a intraaxial large mass compressing the ipsilateral as well as contralateral ventricle.
Hmm.
More of solid cystic components, sir.
Okay.
Um,
There's contrast picture also. Can you comment on the contrast pattern?
there's homogeneous contrast in
This is homogeneous, you think?
Heterogeneous and all.
so solid. Yes, sir. Heterogeneous, sir.
The solid part is enhancing, right?
Solid part is enhancing. Yes, sir. Yes, sir.
Okay. And what are the differential diagnoses you feel? Remember, this is a 2-year-old child.
Pilocytic astrocytoma.
Okay. Would you keep that as your first diagnosis?
Jitendra sir, you can push in anytime you want.
Yes, sir. George sir, Jitu sir,
Okay, okay.
please go ahead. We have time, sir.
ETRT.
What is ETRT?
Typical atypical rhabdoid teratomas.
Okay. Sir,
ATRT
Jitu sir,
on
George sir, you can please pitch in with questions. These are just representative questions. You can
What are
ask.
the differential? What are the differentials still now given by Paras? This question is to Paras.
Yes, sir.
so
Paras,
first
what
is
is
pilocytic astrocytoma
pilocytic
and second ATRT.
second ATRT? Why you kept ATRT second compared to like
Hmm.
pilocytic? What is the typical localization location for pilocytic in pediatric age group?
Midline.
Supratentorial.
Supratentorial.
Posterior fossa.
It is posterior fossa. It is infratentorial.
Okay.
More high grade is
Yeah, I
high
think
grade
so.
tumors are more common when it is in the infantile group. So this is close to infantile group. So what high grade tumor? ATRT1. Okay, then what else?
Spindle cell tumor, sir.
Which one? Sorry,
Spindle cell tumor.
Spindle cell tumor.
spindle cell tumor. Yes.
Okay.
What are the
Spindle cell
pediatric
tumor is a
high-grade
broad term.
pediatric diffuse gliomas that you know of? Any pediatric diffuse gliomas name that you know of? Paras, this is to you, yeah. Dr. Shiv, any pediatric diffuse gliomas that you know of? Is there something called as glioblastoma in pediatric high-grade gliomas?
Yes.
No, sir.
Yes. There is nothing called as glioblastoma in pediatric
No.
glioma.
Diffuse midline glioma or something you know of.
What is diffuse midline glioma?
If a tumor originates from thalamus in case of pediatric, where does it localize? What is
Absolutely.
it known as?
Yeah.
So optic
Is it a hemispheric or is it midline?
hemispheric.
Okay, you can go to the next one. What further
Okay.
investigations?
What investigations would you advise?
You have to read pediatric midline gliomas. Okay, Dr. Shiv and Paras both.
Dr.
Yes, sir.
Paras, any particular investigation would you like to advise in this patient before going for management? Apart from the routines, of course.
Paras, these cases you must be seeing regularly, right? What do you do at your
Yes.
center? Just answer that. Don't shy
Yeah.
away from answering.
Hmm.
This is for you to learn. We are not judging you here. This is not your final exam. Nothing is going to go wrong. Relax and
MRS,
just answer.
MRS
Yeah.
spectro, MRS spectro
MR
and DTI.
Okay. Anything else?
DTI and MRS spectro, sir.
Would you like to screen the whole spine?
For the leptomeningeal
Yeah.
spread.
Yes, sir.
What
Okay.
else will you
Yes,
like
sir.
to do in a child with a 2-year-old if you're going to operate this case? What is the one thing more important than MRS spectro, DTI, which I
Polyphonic
would
screening.
No, more important, something very basic which I would like to know before I go in this operating this case.
Tractography, sir.
Come on, man.
It's done.
What is the blood group of the patient? तुम्हें blood
Okay.
मिलेगा नहीं, patient will die on table on you.
Okay.
Come on, see basic things, man. You're going to operate this case. What are you asking for basically? Then what else? How are you going to position this case? Are you going to
Lateral
use
position.
pins or not?
No, we are not.
Lateral position.
So we
Okay,
are not.
lateral is fine. Meaning I can accept lateral, no problem. It is
Okay.
fine. Are you going to use
No,
pins?
sir. No, sir.
Why not?
Why not?
So less than 4 years.
I will
Is
try
there a
to
rule like
optimize.
that?
So bones are very.
Whatever you
You
no.
can use. You can
In
if
case
you.
of any bleeding, sir, we can easily fix the patient too.
And what else?
You can very well use pins, okay?
Yeah,
Don't
absolutely.
keep yeah, you can very well use pins. No need for lateral. Okay. And one more thing I want to discuss here, there is T2 hyper or this cystic component,
Yeah.
which is inverting on flare. What do you understand by inverting on flare, Paras and Dr. Shiv?
That is suppressed by there is a fluid
Cystic component is also.
cystic component.
Okay.
So
Chalo,
I'll
next.
proceed to the next case, Paras. This is a 23-year-old female presented with low backache for 20 days, aggravated on prolonged sitting. On examination, there is a focal tenderness over the left sacral region with no neurological deficit. Can you see the scans? Describe the imaging findings. And of course, what's the most likely diagnosis?
So subcutaneous.
Paras.
Paras. And you also reconsider your answer.
Sorry, sir. I know people.
It's a very representative image. He has just given specific cuts. Why has he given those specific cuts? See, the SSD also just shows a very, very specific thing.
I've not seen it.
So
No.
subcutaneous.
No, look at the bone, ma'am.
Can you see the coccyx?
Yeah, look
Yes.
there.
Oh.
So lesion. Coccygeal.
What is it?
Okay. Lower sacral or coccygeal, what? You can give differentials. Whatever tumors you see commonly at this area.
Sacral chordoma, sir.
That.
Okay. Another image. Another. In the 3D recon, if you see, there are septae inside it. I'll give you a hint. It had fluid levels also.
Teratoma.
Teratoma. Other.
ABC.
Yeah, very good. ABC.
So cyst.
Do you have to tell what ABC is for everyone who's listening?
Aneurysmal bone cyst.
Aneurysmal bone cyst.
Yeah. Yes. And giant cell tumors.
Cord.
Okay. What are the treatment options? Before that, how will you manage the patient? Jitu sir, any questions you want to ask? And George sir?
No, going on side. So somebody in the some comment I read, this is somebody has written Tarlov cyst. It is
Yeah.
completely blue.
Please
No.
do not
big
write
here.
Tarlos. Yeah.
And if someone has to, my question is,
It's
if someone has to have a ABC in the spine, what is the most common site?
Yeah.
This is not, is it the most common site? To be
No,
making
sir.
it as a first stage diagnosis. Okay.
Long bones are more common. Bones
स्पाइन में बताओ ना, या तो स्पाइन में
Spine,
बात
spine.
करा है.
in spine.
One hint is it is diametrically opposite to
Cervical.
what is being shown.
Cervical,
Yeah.
sir. I've seen one
Right.
cervical case, sir.
That is why what else? Okay.
Okay.
ठीक है.
So how will you approach this patient? What will you prefer
And
surgical
doctor-
approach? And what will you
See,
take utmost care of?
Paras, why are you hesitating in the approach? What is the approach? There is only one approach. What will you do in this case?
Sir, I will try to embolize the feeding vessel first.
You'll do an NGO and try to embolize. Okay.
Then
Will you go in and excise the
con-
tumor?
Excision.
After embolization, I will try to excise, sir.
From where? Which route? Posterior, anterior? I think it's very obvious though.
Posterior. Sir.
Okay. So what care you have to take, utmost care in this patient especially, about the incision?
Sacral.
oh man, about the incision, will the incision be low, high? Will it be near something?
Yeah.
Near around the
Near the
anal
anal
sir.
portals.
So there will be
Yeah.
injury to
There
Anal
can be
portals will be there.
sphincter's injury will be there, sir.
I was only worried about the swelling part, but it's okay.
Sure.
Okay, Harsh.
Sir, some parting comments for both the candidates, please. From both the examiners, please. What all did they need to improve? Anything you want to tell them?
So I think both of them made a good attempt, but what we have to understand is that in every practical exam there are three milestones. Okay, the first milestone is your passing limit. So both of you probably have just managed to pass the first milestone. The second milestone is reaching a distinction level, and the third milestone is the highest level, where is you try for a gold medal or something like that. So for, if you see, for both these cases, the first case maybe vestibular schwannoma, your first milestone is maybe getting up to the differential diagnosis, your basic operative approach. Your second milestones will be going into further nuances of the operative procedure, complications, that is to reach a distinction level. And maybe some sort of radiological classification, multiple other approaches. So it depends on where you take the examiner to. So when you finish the first milestone only, you will reach the second milestone, and the third milestone is when you talk about, say, some series of vestibular schwannomas by quote some authors and things like that. This is just an example. And also remember that we are preparing for not just this theory exam or the practical exam, we are preparing for the exam of life. So tomorrow you may have to face other exams. So some of you have both MCH and DNB. Some of you will be facing some foreign exams like FRCS, EANS, and there you won't have kind examiners like Dr. Harsh and Dr. Jitendra. So here they were constantly leading you to the answer by giving you clues, asking you the second time, and you don't find kind examiners for these foreign exams. So they will be exactly stone faced, poker faced, and they will just not even make any expression. So they have a set of 5 questions, and they will tick as soon as the question is asked. They have an answer key before them, so they will never lead you to the right answer. So please be prepared to give the right answer without getting clues or getting something which orients you towards it. So, and there is a time limit in all these exams where they have 5 minutes to ask you this, and within 5 minutes your answer is you have to hit the right answer. So there is no clue and things like that. So my urge to both of you would be that to push to the next second and the third milestone. So you have done to reach the first milestone, but please try for the higher milestones as well. And many thanks to Harsh and Jitendra and Prashant for all your efforts. Thank you.
Thank you, sir.
Thank you, sir.
Sir,
Jitendra, sir, please.
sir.
Yeah, I think sir has completely already make very well
Sir, I have one
useful
question, sir.
comment.
Yeah, Paras, please.
Yeah,
go
yeah,
ahead.
please, Paras,
Sir,
please.
burning sensation is because of which tract, sir? Because many times I've mentioned posterior column, spinothalamic. I got confused, sir.
No, it is definitely not posterior column.
Okay, sir.
It is a spinothalamic tract. See, it is a positive symptom of certain sensory tract. Yes, George, sir.
Yes, I also completely agree. It's not posterior column, it's a dysesthetic sensation.
Yes, sir.
Okay, sir.
Yeah. So I think, sir, George sir has made well formulated comment on for both of you. You have done your best, and I think you have to just practice. That's all. You people know the things, but you don't speak up. So it is for everyone. We were also like this only. Each and every one of us were like this only to the begin with. But you just practice more. That's all. And you have theoretical knowledge, but you are not speaking it up. My best wishes to you, and thank you for presenting here. Thank you, Dr. Prashant and Dr.
Thank you,
Harsh.
thank you,
George sir,
Thank you,
sir,
sir.
thank you so much for being here.
For encouraging.
Thank you.
Thank you, sir.
Thank you.
Thanks,
thank you,
sir.
sir.
Thank you.
Bye.
Thank you, everyone. Thank you, Harsh. Thank you, sir.